Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute myeloid leukemia with other defined genetic alterations. These are super rare entities, and they currently include 5 entities that I'm going to go through them quickly. The epidemiology of these entities varies widely depending on the specific alteration, but they are generally super duper rare. Morphologically, they are pretty variable. For example, one of them is characterized by CAT6A CREBBP Fusion. This one shows monoblastic features, for example. The immunophenotype varies with the subtype. Entities with monocytic features are going to show monocytic markers like CD14 and CD64, and others with megakaryoblast features are going to show expression of megakaryoblast markers. The molecular findings include a range of rare translocations, such as CBFA2, T3, GLIS2 fusion, and other fusions that we're going to talk about in this video, and these often involve key regulatory genes. The essential criteria to make a diagnosis of any of these entities would require the presence of at least 20% blasts in the peripheral blood or bone marrow with myeloid immunophenotype, meaning expression of myeloid-associated antigens like CD13 and CD33. You also need the detection of one or more of the specific cytogenetic or molecular aberrations that we're going to discuss regarding each entity in a patient with acute myeloid leukemia not fulfilling diagnostic criteria for AML with defined genetic abnormalities, not fulfilling diagnostic criteria for acute myeloid leukemia myelodysplasia related, and not fulfilling criteria for AML post-cytotoxic therapy or mixed phenotype acute leukemia. And the prognosis is generally poor for these entities. The first entity that I'm going to cover is going to be AML with CBFA2T3 GLIS2 fusion. This entity is exclusively seen in children aged less than 5 years with the highest incidence during infancy and is often associated with non-Down syndrome-related acute megakaryoblast leukemia, which comprises about 18 to 30% of newly diagnosed childhood AML cases. So out of this, I want you to remember that it's seen in children less than 5 years and usually has a megakaryoblast differentiation. Histopathology usually shows megakaryoblast differentiation. And as for the immunophenotype, more than 50% of cases show the RAM phenotype. And the RAM phenotype is basically RAM stands for the initials of the first patient on which they identified this immunophenotype, which is strong CD56 expression, lack of HLA-DR, and an underexpression of CD45 and CD38. The molecular findings that are usually seen in this condition, you have to have the CBFA to T3 GLIS2 fusion. Sometimes you can see in version 16. And to make the diagnosis, you need to identify at least 20% blasts with myeloid immunophenotype. You need the CBFA2 T3 GLIS2 fusion in a patient with acute leukemia not fulfilling diagnostic criteria for AML with defining genetic abnormalities, AML myelodysplasia related, AML post-cytotoxic therapy, or mixed phenotype acute leukemia, and it has poor prognosis. The second entity that I'm going to discuss is going to be AML with CAT6A CREBBP Fusion. This is a rare entity that can occur at any age, often is acute monoblastic or monocytic leukemia, and is frequently associated with erythrophagocytosis in about 70% of the cases, leukemia cutis in about 58% of the cases, and DIC in about 39% of the cases. So this is the most high yield part about this leukemia: erythrophagocytosis, leukemia cutis, and DIC. Immunophenotype: CD13, 33, HLA-DR, MPO, and CD15 positive. And sometimes it shows the suppression of CD56, CD14. It's usually CD34 negative and CD117 negative. Molecular findings include the CAT6A CREBBP fusion. Translocation 816 would result in this fusion. Other molecular findings would include ASXL1, FLT3, TP53, RUNX1, and TET2 mutation, and complex karyotype can be seen. To make this diagnosis, you need at least 20% blasts with myeloid immunophenotype. You need the CAT6A CREBBP fusion, and the leukemia should not be fulfilling diagnostic criteria for AML with defining genetic abnormalities, AML myelodysplasia related, AML post-cytotoxic therapy, or mixed phenotype acute leukemia. The prognosis of this condition is similar to transient abnormal myelopoiesis in Down syndrome. Spontaneous remission may occur in children in the early neonatal period. Some cases with spontaneous remission subsequently recur, and in adults with CAT6A CREBBP AML but no prior cytotoxic therapy or antecedent myeloid neoplasm, allogeneic stem cell transplantation can substantially improve outcome in these patients. So the highest yield thing for me in this entity is frequently associated with erythrophagocytosis, leukemia cutis, DIC, and as for the immunophenotype, they tend to be CD34 negative and CD117 negative. Now I'm going to discuss AML with FOS-ERG fusion. It's a very rare entity, mainly found in young adults. There is no specific morphologic differentiation pattern. However, no erythroid leukemia is seen, or no erythroid differentiation is seen in this entity. It doesn't have any specific immunophenotype. FOS-ERG fusion translocation 1621 is essential to make the diagnosis. Gain of chromosome 8, 10, and complex karyotype can be seen in this entity. And it's similar to the other leukemias that we discussed in terms of essential criteria. The only difference is that you have to identify the specific FOS-ERG fusion, and this entity has poor prognosis. As for this entity, it's AML with MNX1 ETV6 fusion. This constitutes less than 1% of newly diagnosed childhood AML cases, but as many as 1/3 of the cases in patients aged between 0 and 2 years. The blasts here have no specific differentiation pattern, but about 10% show a megakaryoblast differentiation. As for the immunophenotype, they may express T-cell markers in addition to myeloid markers. And then for molecular findings, MNX1 ETV6 fusion translocation 712 is seen in this entity, and most cases have trisomy 19. The essential criteria is similar to the previous cases, and you have to identify the MNX1 ETV6 fusion, and this entity has poor prognosis. And the last entity that I'm going to discuss today is AML with NPM1 MLF1 fusion. It's a very rare entity in which the blasts have no specific differentiation pattern, but multilinear dysplasia can be seen. The blasts have no specific immunophenotype, and in about 70% of the cases, translocation 35, which is the NPM1 MLF1 fusion, is the sole chromosomal abnormality. Trisomy 8 is the most common specific additional chromosomal abnormality, and about 10% of the patients have a complex karyotype. The criteria to make the diagnosis is the same as the previous entities, and you have to identify the NPM1 MLF1 fusion. And as for the prognosis, it's generally poor. However, allogenic stem cell transplantation may substantially improve outcome in these patients. This is the end of this video, and see you next time.